Today I'm discussing my work on the use of metabolomics technologies to actually predict acute kidney injury after transcatheter aortic valve replacement. Metabolomics is essentially the study of small molecules. These are molecules that are essentially downstream of all the regulatory pathways that occur within an organism, within a cell, or a tissue type. So once you go from a gene to a protein, metabolomics are essentially the next level. And they essentially reflect all the different pathways that are occurring, again, within an organism, everything from cholesterol biosynthesis and metabolism, lipid metabolism, protein and amino acids, essentially covers every pathway within our bodies. Because these metabolites essentially reflect every biological pathway that happens within our bodies, we can use it to predict various outcomes and to get some insight into a specific biologic process. So my work specifically, and the work that I presented today at this meeting, was actually using metabolites to predict acute kidney injury. We collected blood samples in patients that underwent transcatheter aortic valve replacement. We got the blood before they underwent that procedure and assayed that blood for almost 100 metabolites, and then essentially looked to see if any of those metabolites first correlated with the degree of renal function, and then looked to see if any of the metabolites actually were predictive of kidney injury after the procedure. So these are essentially the way we're essentially putting this together is we're identifying metabolites that relate to renal reserve. And so one would expect that if one has lower renal reserve, that you can't make it through a procedure as complex as TAVR with the many insults that may occur to the kidneys without developing acute kidney injury. To date, because most patients that undergo TAVR are elderly with multiple comorbid conditions, almost all of them are at high risk for acute kidney injury. And that's really been the challenge and why we think there's essentially a strong need for work like what we're doing, is that we need better risk factors and better predictors to even determine who we should study. And so first, the impact of this work, not only will we be able to better assess risk as when we have a conversation with our patients about the procedure, but in addition to that, we can start to understand who's at risk and then investigate preventative measures. So there are several things you can do, such as reducing contrast, hydrating these patients. For example, we've actually even done one case with no contrast at all in somebody who we felt was at high risk of developing acute kidney injury. So there are several things we can investigate once we actually understand who is at risk of having this problem in the first place. We don't know yet. So we have identified essentially a metabolite that is a marker or a predictor of acute kidney injury. The next step is figuring out why. And so it's very possible that this metabolite that we've identified is simply a biomarker for, again, reduced renal reserve. It's also very possible that this metabolite is causal, meaning that for some reason these individuals have higher levels of the metabolite, and it's those higher levels that are actually to some extent toxic to the kidney. So we don't understand that relationship yet. That's going to require further work, likely in some animal models, to try to determine the mechanistic pathways through which this metabolite acts in the kidney. The one thing we do know is that the kidney is responsible for the excretion of 5-adenosylhomocysteine, which is essentially the metabolite that we've identified. And so we think it's providing us a marker for another axis of renal function. It's an issue potentially for multiple specialties. I would say cardiologists, nephrologists, potentially there's some hormonal axes as well to involve endocrinologists. This could enhance our understanding of what the best methods are to measure renal function. At this point, we focus largely on filtration but certainly the kidneys are not simply a giant filter, as the nephrologists know, and perhaps us as cardiologists are just starting to realize that. The kidneys are metabolically active. They have many other processes and pathways that are active within the kidneys. And so again, this is why we think these metabolites may reflect or provide a novel measure of renal function that again goes above and beyond filtration, which is what we've been limited to date in terms of understanding renal function. I would say the first step, our study is the first of its kind. It's performed in a relatively small cohort at a single center. So always when you have this sort of study, the first step is to validate it. So what we need to do is actually to amass a larger cohort of patients and ones that have more diverse backgrounds, for example, perhaps not just transcatheter aortic valve replacement, but people undergoing other procedures as well, and essentially validate our results. If they are consistent and if this marker is predictive in the wide range of patient populations, then I think we very quickly could move into applying it in the clinical setting. I do think that we have sufficient sites to perform the procedure. I would say that's perhaps a little bit, likely won't be impacted by this type of work. TAVR, you're absolutely right, it's not performed that frequently, and that's largely because we've been limited to high risk and extreme risk patients. I think largely from data that we've learned here at this meeting, we're expecting that we'll shift to healthier populations, to intermediate risk populations. But currently there's over 400 TAVR sites within the country. That's expected to expand a little bit, but I think we've essentially saturated the sites that have the infrastructure and the expertise at the site to actually be able to do TAVR safely.